Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years.
Hello and welcome. Today's presentation is presented by Dr. Thomas Collins-Pallett. Dr. Collins-Pallett is a family medicine specialist with Washington Township Medical Foundation. He earned his medical degree at St. George University School of Medicine and completed his residency at Stanford Hospital, Columbia University. Without further ado, please welcome Dr. Thomas Collins-Pallett.
Hello everybody, my name is Tom Collins-Pallett. I'm a family medicine physician, and I'm going to be talking to you guys today about obesity and how weight can affect your health. I don't have any disclosures, and to give you guys an outline of what we're going to be talking about, I'm going to go through definitions, so basic BMI measures. We're going to talk about prevalence both in the States and worldwide. We're going to talk through some risk factors for developing obesity as an adult, and then we're going to go through health impacts that obesity can have for you. And then we're also going to discuss benefits of weight loss and some improvements we can see. Some basic definitions, and there's lots of problems with BMI, but it's very readily available to us just because it's, your height and your weight. And so a lot of the population studies and the data we have just has BMI to go off, and so that's really what we rely on. So underweight would be less than 18.5 for a BMI. Healthy weight tends to be between 18.5 to 25. Overweight is greater than 25. And then we have the classes of obesity moving up from 30 to 35, and then greater than or equal to 40. So going through prevalence and getting more and more prevalent ever since they started up this National Health and Nutrition Survey. Since 1988, it's almost doubled. It's based on 2018 data. And class 3 obesity in the States, which is that BMI greater than 40, has basically doubled in the last decade. So it's definitely a problem we're seeing more and more often in the States and worldwide. So there's 70 countries worldwide that have seen similar numbers. As a Canadian, I always look at Canada too, and we are not doing any better. So we've actually more than doubled over the last decade. Our total numbers are not as good either. So it's affecting pretty much everywhere. So now some state-specific data. This is a different survey than the NHANES study, but we can see down on the bottom right, there are rates of obesity listed. And this is a picture from 2011 data, and then this is 2019 data. And as you can see, pretty much every state except Colorado and Florida have seen an increase in obesity rates. And that's been true prior to 2011 as well. So this continues to be a problem that is worsening kind of across the board here. Now, there's a lot of stigma associated with obesity, and I think risk factors are really key to talk about when you're discussing that stigma, because if you look at this risk list here, it could be pretty much any other medical condition, right? So we have genetics is a major factor that impacts this. So based on the study data, they have anywhere from 40 to 70% of adult obesity could be attributed to just genetics. The maternal environment is really important as well. So basically there's a theory called the thrifty gene hypothesis, which is relatively old but has been borne out in some more recent studies. And it shows that when moms are pregnant and are under higher levels of stress, their children tend to hang on to nutrients better than kind of equivalent mothers not under those high levels of stress. And they looked at, classic things like famines in certain countries, world wars, stuff like that. And really noticed children born, to the same parents, but during a highly stressful event, tend to hang on to nutrients a little better. Your socioeconomic status is obviously a big impact here. Child and adolescent weight is certainly a factor as well, and this is why if you see me or any other family medicine physicians in clinic, they're probably going to talk to you a little bit about healthy diet and exercise in your kids. And then, certain medical conditions, thyroid problems, other hormonal problems. Age is a risk factor for this. Sleep problems, stress, even just on your own, not related to the maternal environment. Night shift work, and then, lifestyle factors. And one of the big things to notice here, not a lot of these things are modifiable, right? So we have a couple things that we can really hone in on, but obesity is very complex, and it's not really just diet and exercise. There's a lot of factors here, that some of which we can maybe modify a little bit, and some of which we can't at all. So going into some of the health impacts for obesity, and this is kind of the more depressing part of my presentation here, but they looked at the Nurses' Health Study out of Boston, looked at data of about 120,000 people, and they risk stratified them based on their weight. And one of the things they showed was for diabetes, over the course of 14 years, if your BMI was greater than 35, you were 100 times more likely to develop diabetes than those with a BMI less than 22. So that's a pretty significant increased risk. Blood pressure, this is also from that same study. They showed about 40% of new diagnoses of high blood pressure were attributed to weight. Heart failure, this is from the Framingham Heart Study. They showed, increased risk for every unit increase of BMI beyond 25 of 5% in men, 7% in women, and that is pretty significant. So a 5 increase. So if your BMI is greater than 30, we're talking about a 1 in 4 increased risk, or more than a 1 in 3 increased risk if you're a woman. AFib. This is also from the atherosclerosis risk study and risk in community study, and also some data from the Framingham study showed that 1 in 5 cases of AFib could be attributed to obesity, and then Framingham was the one that showed that increase in BMI, also increasing your risk by 5%. Just general population data, there's a linear association between weight and risk for coronary artery disease. So you are definitely at higher risk for having a heart attack if your weight is higher. And then mortality risk, kind of the sum of the parts here. Those with a BMI greater than 29 were at twice the risk of mortality as those with a normal BMI, and even those that are overweight have an increased risk, a 1.3 fold increased risk. Just some graphs kind of showing that linear relationship between weight and some of the things I mentioned. One of the ones I didn't go through yet was gallstones, which is the cholelithiasis up in the top right there. But really this is just to illustrate weight, and these problems definitely have this linear relationship. And then in a similar vein, this is a fairly massive population study looking at mortality risk, and down at the bottom there you can see baseline BMI, and then you can see that mortality risk is increasing as your BMI increases. You'll notice kind of an interesting thing. There's a sweet spot there between 22.5 and 25, and there's some debate about why that's there. But I would really focus on in this case that you'll notice once you get above 25 and as you continue to increase for BMI, your mortality risk will also increase. Also, one of the things we don't tend to think about, but cancer risk and obesity, definitely been demonstrated for a few different studies. Endometrial cancer, 2 to 4 times increased risk, esophageal cancer, liver cancer, and as you can see, there's quite a few associations here to be concerned about. One of the biggest ones I see actually in clinic, and I think this is a big motivator for people, is arthritis. So a lot of the time, people will have gained a little bit of weight, whether it's because of a pandemic totally changing everything or other kind of uncontrollable factors, and they'll notice they're having a lot more joint pain, knee pain, hip pain, and that's really highly associated with weight. And we kind of see that in a couple different studies. They looked at hip risk for involvement, and it was almost, a 93% increase if your BMI was greater than or equal to 35, and then 7-time risk increase for knee arthritis for those with BMI greater than or equal to 30. So not insignificant. So now the good news, what can we do about it, kind of part of this presentation. And we have a lot of good data that shows even a little bit of weight loss can make a big difference for most of these problems. So this is looking at similar data from N. Haynes, actually. They showed 2.5 to 5.5 kilogram weight loss over 2 years drastically reduced your risk of developing diabetes, right? So that's a pretty big impact, and not, I would say, an unreasonable amount of weight loss to consider over 2 years. When we're talking more weight loss, and this is specifically for people already with diabetes, between a 5 and 10% body weight loss over a year showed improvement in your A1C of 1%, which is also pretty significant. That's the difference between, an added medication. That's the difference between poor control and good control. So we can see some really good improvement there. Other things, I see a lot of abnormal cholesterol in physicals, and they've really demonstrated weight loss can improve that. So 5 to 8 kilograms improves triglycerides. It actually increases your good cholesterol and decreases your bad cholesterol. So all the things we get concerned about on that lipid panel improve. And they've also demonstrated a dose-response relationship between weight loss and blood pressure. So at around 5% weight loss, you are seeing an impact that can be the same as an added medication, very similar to that diabetes point I mentioned earlier. Arthritis, we already talked a little bit about, but major improvements. You can see major improvements in symptoms, and this is based on the IDEA trial that looked at about 500 people with arthritis and put them in a weight loss program. And they showed that around a 7% weight loss improved arthritis symptoms across the board, and that when you hit 11% weight loss, then half of people are improving pain, and more than a third of people have no pain, which is really significant for me. Again, that's a medication you don't need to take anymore. So to give kind of a brief overview of what we talked about today, obesity definitely becoming more and more prevalent. It's very complex, not something we can just attribute to any single cause, and that's really why we have to focus on what we can adjust in lifestyle. And it's a major risk factor for developing other problems, but with some weight loss, we can really mitigate that risk. These are the major references I mentioned. So N. Haynes, BR, FSS data, CDC website, the Nurses' Health Study, the Framingham Heart Study, atherosclerosis risk and community study, the IDEA trial, and there were a few other minor references that are available on request. Does anybody have any questions?
10 years ago, I lost 50 pounds. Then over time, I gained 25 pounds. I am back to trying to lose weight again. Is it bad to keep losing and gaining weight? Are there long-term effects if this pattern continues?
So that's a great question. And they've actually looked at this a couple different ways. That kind of bounce around that people have where, and I see this especially when people are following certain diet plans, is actually puts you at higher risk for a lot of the stuff we talked about today. It's definitely much healthier to have a really controlled weight loss that is sustainable as opposed to kind of a bounce up and down. I always look at net weight, right? So if we're at highest weight, then we can talk about how to improve that. But if you drop a little bit of weight and then only gain a small amount of what you dropped back, that's good, right? We've got a net positive here, and then we can focus on kind of problem solving, how to get things even better for you.
Let's say two people of similar build need to lose weight. They're the same age, gender, etc. They follow the same activity and diet plans. Over 2 months, one loses 10 pounds and the other only 2. Why does this happen? Is there anything additional the 2-pound weight loss person can do?
So another good question. There's a huge range of things that could be going on, right? And this really goes back to the risk factors I talked about. So just because they are the same criteria for age and everything like that does not mean they have the same genetics at all. There could be some underlying health issues that we haven't found yet. And in terms of approaches, I think it's really got to be individualized, right? So if somebody were coming into clinic and I were talking to them about that, we'd really have to see, is this plan that you and your friend are doing, is that the best one for you? Because everybody's got to find something that works for them and that's sustainable for them. And it's not a one-size-fits-all situation at all. And there's certainly other things to talk about. There's medications we can occasionally use to help. I don't tend to start with those, but that can be reasonable, especially when we're trying to overcome some major genetic risk factors as well.
What are the risks of rapid weight loss?
Yeah, so I'm always concerned, and this goes back to that first question, that if we're dropping weight too quickly, it's not going to be sustainable. And there are a ton of diet plans out there, and they'll advertise lose 1 million pounds in 5 seconds. And I find most of that stuff is not really sustainable, and you will gain some weight back. And that kind of goes back to that first question for risk. People that do that are actually at higher risk for some of the things we talked about. Heart disease, diabetes, stuff like that. So I'm always focused on something that's sustainable. I always say if we're picking a diet plan, I want you to be able to do it for the rest of your life. And I think slow weight loss is weight loss, right? If you lose a pound a month, great. That's a pound, right? That's fantastic. You'll get there eventually. All the risk stuff we talked about here, weight loss is never a race. It's about eventually getting to the goal and kind of problem solving along the way, but we should never be trying to drop a ton of weight really fast.
This concludes our program. Thank you, Dr. Collins-Pallett, for your expertise, and thank you to our viewers for tuning in. The entire broadcast of today's event will be available on our Facebook page and YouTube.